Patients who receive BCG essentially are those patients in whom we feel that there's a very high risk of recurrence and or progression. Those are the rapidly recurrent low-grade tumors or the high-grade tumors. And those are exactly the patients in whom we do not want to miss recurrences. So the fact that we can use blue light cystoscopy in these patients means that we're essentially using enhanced detection methods to detect recurrences earlier on in the appropriate patients. So the fact that these patients are on BCG means that they're high risk already, and they need everything we can do to detect the recurrences earlier on. This will be a major advance in the care of our patients. The fact that we can now use blue light cystoscopy with Cysview at the appropriate time point after BCG is going to be critical. For example, after induction BCG in a high-risk patient, which is once a week for 6 weeks, we wait 6 weeks and perform a cystoscopy. And if you can use blue light cystoscopy at that appropriate time point, it will help us detect recurrences early on and hence counsel our patient on the appropriate next step. After maintenance BCG, which is once a week for 3 weeks, the standard of care is to wait 9 weeks and then perform a cystoscopy. And the fact that we can again use blue light cystoscopy at the appropriate time point will help us not miss any recurrences that might be occurring. And the ramifications are huge, because if a T1 high-grade patient has an early recurrence, those patients are at a very high risk for metastatic disease and they need to be counseled on early cystectomy. If a patient has another high-grade recurrence, that's also crucial and might call for a change in the therapy. So the bottom line is being able to use blue light cystoscopy at the appropriate time point is going to be critical for our patients. There's always been a fear that if you use enhanced detection techniques such as blue light cystoscopy too early after intravesical therapy, it might cause patients to have a false positive. In other words, we will detect so-called recurrences that don't exist. The key data was that this was not the case. If you perform blue light cystoscopy at the appropriate time point after BCG, there is no relative increase in the detection of false positive findings. Patients nowadays have cystoscopy performed under local anesthesia in the office, and that's almost always done with a flexible scope. There are still a few centers that will use a rigid scope in the office setting, but the fact that we can now use blue light cystoscopy in the office setting, which is the flexible cystoscope setting, allows us to avoid anesthesia for our patients, which is something we have to do traditionally if you use the rigid scope, because that's the setting in which it was approved prior to this new data that came out. So the fact that we can now use it in the flexible cystoscope setting, the rigid cystoscope setting, essentially means that we can use Cysview at the appropriate time in the appropriate setting for the appropriate patient. It's a major step forward in not only the care of our patients, but in our ability to personalize therapy for patients. Personalizing therapy essentially means that for a particular patient, we can offer the best care for him or her at that time. And being able to use blue light cystoscopy for the right patient at the right time, at the right place, clearly is a major step forward in personalized therapy for patients with non-muscle invasive bladder cancer.